This learning object is a production of Abu Dhabi Men's College, Center of Excellence for ICT and Learning Technology.
Good day, everybody. Today I will be talking about congestive heart failure, the clinical manifestations, diagnostic tests, and treatments of heart failure. I will be focusing basically on the pathophysiology of heart failure. Heart failure, the causes of heart failure are many, but the most common are hypertension, basically chronic hypertension. Chronic hypertension is a leading cause of heart failure because, as we all know, hypertension is a silent killer, and having pressure on the heart for a prolonged period of time, that first of all will lead to hypertrophy of the heart, where the cardiac muscle will enlarge in an attempt to accommodate this high pressure. But with time, and if the hypertension is not corrected, the heart will eventually hypertrophy to an extent that the contractility or the contractile forces of the myocardial fibril will be lost and will be weakened to an extent that the cardiac output would decrease. And as we all know, that the cardiac output is a product of stroke volume and heart rate. And we all know that the stroke volume is the amount of blood pumped with each beat from the heart. So before the heart will try to compensate for that decrease in cardiac output by increasing the heart rate. But again, that is limited. So from this brief idea, you can tell that the first sign of heart failure would be what we call resting tachycardia. So if somebody has got a chronic hypertension that is unnoticed or untreated, and you take their heart rate and you realize that their heart rate is a little bit above normal, that is above 100 beats per minute, that must alert you that this resting tachycardia, that is tachycardia without any effort, could be an early sign of heart failure. So we spoke about chronic hypertension with respect to heart failure. Another cause of heart failure could be recurrent infarctions of the heart. As we all know, chronic hypertension, diabetes, dyslipidemias, all these might cause the coronary arteries to become blocked and clogged. So if a part of the heart that is supplied by a certain coronary artery, if that coronary artery is blocked, consequently the area supplied by that coronary artery will not get enough blood, and the area would sustain what we call infarction or death of those cells. So if, for example, if like 10% of the left ventricle is damaged, it means it is working less by 10%. I would have what we call hypokinesia. With time, this infarcted area would not work at all. However, a certain coronary artery does not only supply one area, it supplies different areas in the heart. So you would have different consequences of that decrease in blood supply. Certain areas will be ischemic. Other areas would be infarcted. The ischemic area, because they're not getting enough blood and oxygen, they would have weakened contraction, or what we call hypokinesia. However, the areas that are totally deprived of blood, they would die and they will have akinesia. Akinesia means absence, total absence of muscular contraction. Now, what really is going to happen now, the cardiac output, because of these hypokinetic and akinetic areas, is going to decrease. But keep in mind, when we talk about the function of the heart, it's not really the cardiac output that exactly determines how much blood is being pumped of the venous return that's coming from the tissues. It's the ejection fraction. I'm really concerned here about the ejection fraction. That is the percentage of blood that is ejected from the heart out of the venous return. So basically, if I have good myocardium and I'm receiving a normal venous return, I expect the ejection fraction to be up more than 50% in a normal heart. So what basically is going to happen now, because I have hypokinetic and akinetic area, blood is going to accumulate in the heart. Not all the blood is being pumped. So the accumulation of blood in the left ventricle and right ventricle will impede the pouring of blood from the right atrium and left atrium, because as we know that blood travels through the valves from the upper part of the heart to the lower part of the heart, the upper part, I mean the atrium, to the lower part, that is the ventricles. However, they travel not only under the effect of contracting auricles, but also because of pressure difference. Pressure difference plays much more important role than the contraction of the auricles. Well, if the ventricles are full and the blood is coming through the superior inferior vena cava and through the pulmonary veins to drain into the left and right atrium, the left and right atrium will try to open to drain the blood into the ventricles, but as we said, that the ventricles now probably are half empty because the blood in them is not being ejected because the myocardial fibers are weak. So blood is stagnating in the left and right ventricle. The stagnation of blood in these two chambers will increase the pressure. And consequently, the pressure difference, the difference in pressure between the ventricles and the auricles will be less. And as I said, for the blood to be propelled effectively from the auricles to the ventricles, I have to have a huge or big pressure difference. But now the situation has been reversed, in which the pressure in the ventricles is high and the auricles or the atrium cannot empty because ventricles are basically full. So what will happen? Again, pressure in the ventricles increase. Now pressure in the auricles is increasing. But as we know that the blood in the left and right atrium is draining on the right side of the heart. It's draining through the superior and inferior vena cava. It's draining the head, neck, and chest, abdomen, lower part of the body. So if blood cannot drain into the right atrium from all these body parts, I expect blood to accumulate and stagnate in these body parts. Consequently, if the patient would have engorged neck veins, if I assess the abdomen, the patient would have hepatomegaly because blood is not being drained through the inferior vena cava and consequently to the heart, so blood would accumulate in the liver, hepatomegaly. I would have splenomegaly for the same reason. The patient would have nausea and possibly vomiting because the intestines would be engorged with the blood, and that would give the patient this nauseous feeling. From the left side of the body, as you know, that the four pulmonary veins are basically draining the lungs. So if the lungs cannot be drained into the left ventricle, blood is going to accumulate in the lungs. The problem here is more severe because in the lung, I expect to have oxygen CO2 exchange. I would expect to have a diffusion of oxygen through the alveolar capillary membrane into the blood, and CO2 from the blood into the alveoli. But this process might be hindered because now I have a lot of blood, a lot of deoxygenated blood accumulated in the pulmonary beds. What is going to aggravate the problem is, as we know, that blood is kept in the blood vessels because of what we call the oncotic pressure. This oncotic pressure is determined by the amount of albumin that exists inside the blood vessels. Up to a certain extent, that albumin will resist and will prevent the movement of blood, or what we call the exudation of blood from the pulmonary beds into the alveolar tissue.